today. And as always, the format is going to be about a 45 minute presentation. If you have any questions throughout the session, please just type them in the chat box so we don't interrupt the presentation. And then at the end, we'll have a Q&A. And if you have any questions, please add them into the chat as well. So without further ado, welcome Dr. Heavey. Thank you so much for being here.
Thanks, Miranda. So I'm going to share my slides. I feel like since COVID, everyone's gotten so much practice that you can't be bad at this anymore. So hopefully everyone can see everything, see the title slide, and we'll go from here. So I'm going to be talking about the opioid overdose epidemic. I'm going to talk a little bit about some national challenges, and then I'm going to look at some local successes. So Erie County has done some amazing, amazing work around opioid overdose. So we'll talk about a couple of things related to that. But just so you know who I am, I'm Sarah Heavey, Sarah Heavey. I'm in the Department of Community Health and Health Behavior here at the School of Public Health and Health Professions at UB, and I also oversee our MPH program. So if anyone's thinking about the MPH program, we can talk about that after. Today, I'm just going to keep it on my research, which is really around psychiatric areas, so mental health, substance use, particularly the opioid epidemic. And so we'll go through some national estimates as I talked about. I'll also talk just briefly about the origins of the opioid epidemic. I think it's really important for us to be aware of that as we're thinking about this problem. And then I'm going to talk about how the Erie County Health Department was really at the forefront of a lot of really innovative ideas at the time. So we'll see 3 local studies that tie into some of the things that we were doing here locally that helped us really start to change the trajectory of opioid overdose in our area. And then I'm also going to briefly talk about the opioid epidemic in the time of COVID-19 and how what we're seeing happening is concerning and hopefully going to be something maybe we could all talk about how to start addressing some of those concerns. So just to kind of give us that context, national drug overdose deaths involving opioids has climbed since the late 1990s. And we're starting to see, so you can see 2017 and 2018, we had a slight decrease in the number of deaths. And so that is encouraging, but by no means does it mean we've addressed the overdose epidemic. And so you do see here in the yellow line, male deaths are higher than female deaths. And this is looking at all opioids from the CDC Wonder database. We also see geographic trends, and unfortunately they haven't updated these maps since 2015, but they just get more red. So you can see over time, starting in 1999, you had a couple of pockets, West Virginia in particular, one in the kind of southwestern part of the US, and then over time the map just gets more and more red, which really just tells us more and more opioid overdoses across the country and in more areas. And this is something we're seeing all over the country. What I think is interesting and ties into some of those changes we're seeing with the national death estimates is we're seeing heroin-involved deaths decrease. So across all urbanicity levels, we're seeing a shift down in the number of deaths. However, we're seeing an increase in the number of synthetic opioid-involved deaths. So many of you have probably heard of fentanyl, which is an incredibly strong synthetic opioid. And the equivalent of maybe 3 grains worth of salt of fentanyl would be enough for someone who's an opioid-naive person to overdose. And so seeing those rates increase is one of the things that makes me really concerned that even though we're maybe plateauing in national numbers, potentially there's greater mortality associated with the opioids that are available on the street. So thinking about heroin laced with fentanyl and some of those components. And I like to bring this up too because a lot of times people think about opioid overdose as a mortality problem, and it's actually a morbidity problem too. So in just July 2016 through September 2017, there were almost 150,000 emergency department visits related to opioid overdose. And so this is something that we're seeing. Of course, the death impact is important, but there's also a lot of illness related to it and a lot of involvement with the hospital system and presenting to an emergency department with opioid overdose. So this is a multifaceted problem that we need to be thinking about kind of across the health system and not just as a death problem or a mortality problem. And so just a note on where the opioid epidemic came from. This is an iatrogenic epidemic. So this is an epidemic that was made by medicine. That's what iatrogenic means. And it came out of, in the mid-1990s, there was a concern that pain was being poorly treated. And that concern was valid. The profession of medicine wasn't doing a great job of recognizing pain and treating pain appropriately. Commensurate with this, new drugs were developed, and you can see here the little gray dude with the band. That's a OxyContin plush toy, among other OxyContin paraphernalia. And the bringing in those new drugs, there were several things, maybe perhaps misleading or inaccurate, that are actually being litigated right now in court against Purdue Pharmaceutical around perceptions that these drugs were not addictive. We've now found out that's not true. And many of these drugs were overprescribed, and there are areas in the country where they're still overprescribed, creating a physiological dependence on these medications. And then as the availability of these drugs were curtailed through prescription monitoring programs and other realizations that overprescribing was leading to addiction, illicit drug demand increased. And that's actually what we're seeing here. So just to orient you to this graph, you can see along the y-axis time, so by quarter between 2009 and 2012. And the reason we're looking at this time frame is because this is when Purdue Pharmaceuticals introduced their abuse deterrent OxyContin. And that happened in the third quarter of 2010. Along the x-axis is time. Along the y-axis is the percentage of people who are using drugs to get high in the past 30 days. And so you'll see that, yes, abuse deterrent OxyContin did reduce the number or the percentage of people using it to get high. That purple line for OxyContin you see decreasing. But what you also notice is the bottom blue line for heroin starts to markedly increase. So people were physiologically addicted to these medications. It changes how your brain makes dopamine and some other things that beyond the scope of the talk today. But that physiological dependence is real, and people started to having to look to other sources to meet that physiological dependence, including heroin. And so this changing demand is really what started driving deaths. Yes, people were overdosing on prescription opioids. However, it was the introduction of illicit opioids that really started to see those increase in deaths. And so you can see here the three waves of the opioid epidemic, first being prescription deaths, then heroin deaths, and then synthetic opioid deaths, things like fentanyl. And because of the potency of fentanyl is, one, unpredictable, because you're not procuring it from a pharmacy, so you don't know how many grams of a substance is in there. But also because the strength of it can vary so significantly, it's a lot less predictable, and it's a lot more volatile for people to overdose on because you don't really know what you're getting. And so let's take a look at this locally, because I think, again, Erie County has done such a remarkable job looking at some of these trends and reversing the course of them. So here's some local data. Between 2012 and 2020, you can see that we saw this increase starting in kind of 2014, 2015, topping out in 2016 with 301 opioid-related deaths in our county alone. And then what's really remarkable is you see this really steady decrease through to 2019, where they've just about cut in half the number of overdose deaths from opioids in our county. And so what I think Erie County did very well is they started changing the context in which people were using opioids. So they had a lot of political will around this, and within the health department and supporting partners, they were able to put in place a couple of really innovative programs to address this epidemic. And so first, one of the things, and we'll talk about each of these individually, but one of the things they did was they started a community opioid overdose and naloxone education program, OEND. And then they also brought in police and fire and gave police and fire agencies naloxone to carry with them. So really major credit goes to Gail Burstein and Cheryl Moore, who's the head of their opioid program at the county health department, because they were really doing these things before a lot of other areas in the United States were doing them. So first, let's talk about community OEND programs. So in the fall and winter of 2019, we had basically this idea that the best responder for an opioid overdose is the first responder. So oftentimes the first responder is the person who's there, somebody that you may be using with, or a friend or a family member, someone who's in the house. And this is because of an opioid overdose happens and it reduces your ability to breathe, and you can only survive for a limited amount of time with a low or no respiration rate. And so the first person to get naloxone to someone in an overdose is without a doubt the best person. And this is where the county stepped in and developed a training to train community members on how to identify and then respond in an opioid overdose situation. Now, I'm sure many of the people on the call right now are thinking, well, yeah, this makes a ton of sense. We should be doing this. We are doing this and engaging in those programs. And just a reminder that this was in 2014 and 2015, right around when we were understanding this opioid epidemic as a problem, as a public health emergency. And so at the time, this was a really cutting edge approach that many areas were not using throughout the country. And so Erie County was one of the first to implement these community-wide programs. So what they did was sponsored trainings throughout Erie County in the fall of 2015. Now they've continued to sponsor those programs. They've continued to run them. They look a little bit different now, but you can actually text for Narcan from the county health department now, which I thought was a pretty innovative and clever idea. So they continue to just be, you know, pivoting and working with the situation that we're in. And what these trainings looked like was they were about 90 minutes of education coupled with hands-on training. And when they started these, there wasn't actually intranasal naloxone. They were actually handing out the intramuscular kits, which were, it came with a syringe, and it was an injection of naloxone that you would, you know, generally in the thigh area, inject somebody with the drug. And then while they were doing the programs, I think it was actually in fall of 2015, they started shifting to those intranasal kits because those were being developed. And so what we did was we looked at, we did some program evaluation with them. So basically we prepared a pre and post survey that all participants took, and it had two main components. The first was knowledge. So were people aware of the risk factors for overdose? What are the signs for overdose? What were the appropriate actions to address an overdose? And did they understand what naloxone was and how it was used? And so this at the time was the only validated scale, the opioid overdose knowledge scale in the literature. So we used that as the cornerstone of our knowledge base for this pre-post test assessment. And we found that overall through the course of the programs, knowledge improved significantly. So there's a 23% increase in knowledge, and this was statistically significant. And so we were excited about that. You know, this program was working to improve people's knowledge. But for those of you thinking, well, I know health behavior, and knowledge is not the only thing you need to shift someone's behavior. The other thing you need are attitudes. And so we also measured opioid overdose attitudes. And so this scale looked at competencies, concerns, and readiness to reverse. So I've included some examples here. It's a little more of a complex, it's not as straightforward maybe as knowledge. And so these were questions like, I'm already able to inject naloxone into someone who is overdosed. Concerns were things like, I would be afraid of doing something wrong in an overdose situation, and then readiness to reverse. So if someone overdoses, I want to be able to help them. And again, what we found was overall attitude scores improved significantly over the course of the program. So we saw about a 15% increase, again, a statistically significant increase. And so, you know, this was really exciting for us because the program that they developed does work. And we're seeing those improved scores across knowledge, so they know what to do, as well as the attitudes to actually engage in and do the overdose reversal. We did ask a couple of other questions of these participants, and we found that nobody at the training admitted to experiencing an overdose personally. Now, this is a very sensitive question, so it is definitely possible that people weren't comfortable admitting this. It was an anonymous survey, but you know, it's a tough question. So it's very possible that somebody had, but they just didn't feel comfortable disclosing it. Many did indicate knowing someone who was at risk or who had experienced an overdose, and several indicated they had witnessed an overdose personally. And that last group, those who had witnessed an overdose personally, had significantly more positive attitudes and greater knowledge coming in to the training. So those were people who were really engaged and informed prior to the program. But even those individuals gained something from the program. So it was kind of a rising tide lifts all boats. Yes, it improved everyone's knowledge, including people who came in and were familiar with it. And I think one of the things that made this training so useful is they actually had trainers show groups of 2 and 3 people how to administer the naloxone. So they showed them how to set up the intranasal system. They showed them how, you know, how the head should be shaped, kind of tipped to receive the naloxone in the best way possible intranasally. And I think it was that hands-on component, not just the kind of didactic quality, but the hands-on of it is what really had the impact with this training. So that was one of the Erie County innovative approaches. The other was, it turns out Erie County was the first county to work with police and fire to make sure all police and all fire agencies had naloxone. And so between July of 2014 and June of 2016, we actually, I was able to look at their overdose reversal reports. And so anytime there was an overdose reversal by a police or fire agency, they filled out this form. And I happened to be in a meeting with Dr. Burstein, and she kindly said, you know, we don't know what to do with these. And I said, I know what to do with these. Let's look at this. So it was kind of one of those wonderfully serendipitous moments in my career. And so essentially what the county did was they went and they did the similar structure of their overdose trainings, their OENDs, specifically for police agencies and fire agencies in the area. They also provided the naloxone kits to these individuals, and the only thing they needed to do was fill out one of these reports afterwards, and that was kind of the exchange for a new kit. So fill out this report, you'll get a new kit. And so over the July 2014 to June 2016 period, they actually reversed 800 overdoses. So really impressive work by police and fire and the county health department. And again, this was the first that we know of, first county to do this. So it was a really innovative, kind of ingenious approach. I think Cheryl Moore came up with it and just deserves all the credit, because it was really very clever. And again, getting the naloxone in the hands of the people who are there first. So over these 800 reversal attempts, 82% were deemed successful. So the person was revived on the spot. That remaining almost 20% were transferred by ambulance to an emergency department. So it is likely that many, if not all of those, were reversed, but unfortunately, because of the nature of the data collection form, we can't say the outcome of those individuals because it was an anonymous form. They didn't collect personal information, so there was no way to tie what happened to that person with whatever hospital records might exist. You can see that the majority of the individuals were male. It's consistent with the national data we looked at the start of this talk. And though the average age was about 31 years, we saw a range of 15 to 71, which is a huge, huge range. And so on this form, one of the questions was response time. And you can see that overall, most people did respond within 4 to 5 minutes. The majority of people did respond to the naloxone administration within that time. There were about 21%, 22% for whom the officers rated as did not work. And in many of those cases, some of those individuals did pass, but some were revived when EMTs came on scene and were able to do intravenous or an IV of naloxone. So some of those, unfortunately, individuals weren't saved, but some were revived by EMT, and then some were transferred to hospitals. And again, unfortunately, we don't have that data. You can also see here were results after administration. So one of the things that's challenging about naloxone is when you administer it, it kind of automatically knocks people into a state of withdrawal. And withdrawal can generally include symptoms like vomiting, seizures. In this case, nobody experienced a seizure, respiratory distress, or what's kind of generically called being dope sick, which is a street term for withdrawal. And it's kind of flu-like symptoms, just achy, feel sick, feel sore. And so what I think is good to know is over half of people didn't experience those kinds of symptoms. Most people did pretty well with the naloxone and didn't have too many kind of negative side effects from it, which I think is good. And on top of that, there's always concern that naloxone administration might make the individual angry or combative. And that happened in a few cases, but by far not the majority. So about 5% were were responsive and angry, and only 2% were combative. So overall, they were generally just uncomfortable and unhappy, but breathing, which is important, and not angry or combative. Okay. And so because of the nature of the data collection form included a response for where the overdose happened, we were actually able to generate this pretty cool map. So this is Erie County. You can see the darkest red areas are in the city of Buffalo. You can see along where the river is, as well as some of the main highways and roads are in kind of a very faint yellow line, just to get you oriented. You can see Grand Island, as well as the north towns, all the way down to the southern tier. And we were able to calculate rates by zip code, which was, I think, a pretty exciting thing for us to be able to see how this was happening. And what we did was we calculated the rates for the population aged 18 and older. And the lightest blue areas had the lowest rates of overdose, and the darkest red areas had the highest rates of overdose. Note, the gray areas aren't necessarily zero. We just didn't have data on those areas. And so we weren't able to include estimates on overdose rates for those localities. And what I think is important for us to recognize, and again, ties with some of this national data that we were looking at, is that you see a mix of overdose rates across urban, suburban, and rural areas. When we look in the city, you can actually see, so the red line coming up and through the kind of from 14202 through 14222, that's Main Street. And then you can see the 198 and the 33, just to, again, orient you to what we're looking at. And note that several areas in the top 25% of rates, those darkest red rates, are actually areas with relatively low population. And so what I think is interesting here to look at is, for example, 14202 had the highest rates, one of the areas with the highest rates of overdose. But when you look at 14202, it's actually because very few people live in that area. And instead, what we're looking at is a park area and industrial zones. And so it's, you know, there's a beach, a concert venue. Frankly, I love to run my Saturday runs along this area. It's just green space and beautiful. So in this case, the high rate was due to this low population. And what we think happened was people were migrating to places that were more neutral territory, where they could purchase and consume drugs in a way that was less evident or obvious if you were in a more populated, more central area of the city. So it may indicate really more that there's kind of a migration for drug use, and potentially people from suburbs coming into the area where they could purchase opioids and then use in those areas. So that was our second study that we looked at with county data. This led us to really wonder around whether naloxone changes opioid use behaviors. And so this is the third study that I'm going to talk about today. And really the driving question for us was, are people using and having naloxone as a safety net so they wouldn't have to worry about opioid overdose mortality, or among, you know, people working this field are people using and having naloxone with them so they can experiment or potentially use more or differently and engage in even riskier behaviors. And so what we did was I conducted one-on-one interviews with 20 adults between 18 to 40 who were in treatment for opioid use, so either illicit or non-medical. I did thank people with a $10 grocery store gift card just to thank them for their time. And these all took place at a local addiction treatment center, the only New York State addiction treatment center for the 8 counties of Western New York. All participants did consent to the study, and we did follow through with appropriate IRB protocols because I did talk with them. They were not, it was all confidential, but it was not anonymous. And so these semi-structured interviews were audio recorded and transcribed, and we did have them fill out what we called our demographics booklet that just got some basic information from them on demographics, as well as some various opioid use behaviors that we were looking at, and education and age and a couple of those kinds of things. And then once we had the transcripts, we did a thematic content analysis using ALICE-TI. So basic questions that we were looking at were around naloxone knowledge, access, and attitude. So what do you know about it, why you have or may not have a kit, and then what kind of use and overdose behaviors they were experiencing. So is this something you thought about having while using? Why not? Kind of probing those questions. So we did have a structured questionnaire, but I left room for following up on things someone might say or bring up as a way to kind of include information we might not have thought to ask. And so of our participants, on average, they were about 28 years old. 40% were female, the majority were single, and the majority had also experienced an overdose. And several of our participants had actually experienced more than one overdose. And in conducting the thematic analysis, we found 5 main themes. So awareness about naloxone, how naloxone intersects with drug selling. We looked at naloxone availability while using, as well as changes in opioid use behaviors, and then naloxone behaviors and opioid overdose mortality risk. So we'll talk through each of these. For our first theme, looking at naloxone awareness, the majority of the participants had heard of naloxone. They were able to recognize it as the overdose drug. There was one individual who wasn't aware of it. They were younger and potentially had less experience with opioid use and opioid culture. So I wonder if that might have been why they weren't as familiar with it. But overall, most people knew of it, but relatively less than half had ever had their own naloxone kit. And so the participants who had kits indicated they primarily obtained them from needle exchange and methadone treatment programs. Now, even fewer had ever used a kit. So only about 35% of our sample had used a naloxone kit on someone else, but the majority had had a kit used on them. So there was some experience with what a naloxone reversal was like personally for people. And, you know, I think that made sense given that many of them had experienced an overdose, and to have it reversed with naloxone was understandable. So the second theme, participants talked a lot about how they'd end up selling opioids as a way to fund their own substance use. And they called this survival selling. And so this was something that was just not what we expected to hear at all. We were really surprised by this finding. And the individuals who talked to us about this talked about how they would ensure they had naloxone with them while they were engaging in survival selling, because around the time we were conducting this study, there was a pretty well-publicized arrest of someone who was selling drugs because someone had overdosed and died from drugs this individual had sold, and he was being charged for that death. And so it looked like the ramifications of that were actually people were looking for naloxone to make sure they didn't end up in a similar situation. And if somebody were to overdose on a drug that they were to sell them, this was kind of an insurance policy for them to make sure that that's not what happened. The third theme looked at feelings or attitudes participants had about naloxone. And so the most common response for participants was that having naloxone while using was just not a priority for them. I think this is nicely summarized in this quote from a participant. I've been in some really dangerous, risky situations where naloxone just wasn't a priority to people that I was with. It wasn't a priority for them. I would be all over the ghetto, then in the neighborhoods with trap houses and drug dealers, where everything was a real quick cop and go, hit and go. So the whole focus and the necessity or the priority of having it was just next to none. So side note, cop is a colloquial term for using heroin. And what I think is really interesting about this quote is the participants really talking about how naloxone is not a priority for their social group, and that using opioids was a quick process. They really tried to use and kind of keep moving, generally as a way to kind of evade any kind of criminal liability or being found by police or such. The fourth theme we came across were how people changed their opioid use behaviors. And so I think, again, this is another one where the following quote summarizes this really well. So we had a participant, he was a 27-year-old male, and he said that I knew that it was fentanyl and that there was a potential that I could overdose. And I told him to get his Narcan ready because I knew what I was about to do, and I fell out just like that. And actually, he had two of them, 2 Narcan things that he had to administer. So here, this participant talked about how he continued to use even though there's a high likelihood of overdose. And his response to knowing that there was fentanyl was to make sure there was naloxone available rather than to not use that particular dose. And as a side note, now I know there's fentanyl test strips that people are able to access. This was kind of pre those, so he thought it was because it had changed colors, but this wasn't when those test strips were available. So the real concern behind this quote is that a lot of people are engaging in those risk behaviors because of naloxone. And then finally, we looked at naloxone behaviors and overdose mortality risks. So a lot of participants talked about naloxone-related behaviors that increased their risk for overdose. And chief among these concerns were uncertainty about when to use naloxone and reasons why they might not want to use naloxone and might hesitate around administering it. And then particularly individuals who use by themselves in an isolated environment. It's a very difficult drug to administer on your own, particularly while you're in the midst of an overdose. So this quote was from a 28-year-old female participant. And she said that the heroin addict's biggest fear is illness. It's getting sick from withdrawal, so you don't want to do it to somebody else that you're hanging out with. But then at the same time, all of this stuff is really embarrassing, but you strive for the point right before overdose, the point of highness right before overdose. So high that you're sloppy and falling over and all that stuff. So basically, for me to Narcan somebody, they gotta stop breathing. And so I think there's a few important concepts here. So one, you don't want to make somebody else sick from withdrawal. A lot of participants talked about how they know the feeling of withdrawal and you don't want to do that to someone else. And then the arbiter for administering naloxone is for somebody to stop breathing. But with an overdose, you can actually have a slowed respiration rate for a significant period of time. And that would actually be the best time to use naloxone because you don't want someone to stop breathing. But that was really what this community was using as their indicator for, okay, now it's time to use the Narcan. She also talked about how the primary goal of using is to achieve that point right before an overdose. And clearly that's a very fine line to approach, especially on a regular basis. And I think this brings us to kind of some conclusions with this study, which were thinking about how awareness for naloxone is high, but uptake is less so. And particularly among those who are using opioids, OENDs may not be the best naloxone distribution point. And they're really, with this sample, they were really relying on needle exchanges and treatment facilities to obtain that naloxone. And then obviously, as we just looked in that quote, you know, their motives for using opioids can influence how they're going to use naloxone. And so are they trying to mitigate withdrawal, or are they using for experimentation? And so I think those of us in public health are really struggling with what's the best way to package naloxone education for people who are using opioids, and how can we do a better job at reaching those individuals and explaining why having this is important and why using it at certain times might be more beneficial than others. And then I think for me, what might have been the most disappointing part of it is there are disincentives to use naloxone. And those include ruining somebody's high and confusion over what's an overdose. And so I think it's really important for us, again, in public health, to be thinking about coming from a harm reduction perspective and meeting people where they are and they're using opioids. And so how do we work to reduce some of the harms associated with that use, rather than judging them or saying, you know, making moral judgments about them as people. It's really about how do we understand their concerns and present information to help overcome those concerns. And so just to wrap up, I wanted to bring up the 2020 data. And I was actually talking with the medical examiner a couple weeks ago about some of this, and they have about 127, between 127 and 135 pending opioid overdose cases. So they haven't fully finished the tox screens and all that kind of stuff, but we're seeing a spike. And if that's true, we are at about where we were for all of 2019 during the summer at this point. And for me, the big question here, is this COVID related? And I'm kind of thinking it probably is. So some of you may have seen the news story around a spike in opioid overdoses in late July, 12 and 24 hours or something like that. And my concern is this is actually kind of wrapped up into the isolation that people feel with COVID-19 and self-quarantine and staying as socially distant as possible. But then also because that has impacted our ability to have naloxone and harm reduction programs. It's reduced the ability for people to have treatment options or treatment availability, as well as disrupting current existing treatment services for people. And that's not in any way saying these organizations aren't doing the best they can. I know they are. But the reality is, because of this kind of distancing and the things we need to do to prevent the spread of COVID, one of the unanticipated consequences is we may undo some of the progress we've had with the opioid epidemic. And so this is just something I'm intrinsically interested in and want to look at more in depth. And I don't think we'll have a good answer for some time, but I think it's really important for us to be thinking about, because planning those changes would be important. And how do we pivot, like the county has done now that you can text for Narcan, and engage in it from that perspective. And then I think also the isolation and depression associated with social distancing can be really challenging for people. And that's a challenge. And it's not an easy one to overcome, and another area of interest for me, but one beyond the scope of this talk. So, that brings me to the conclusion. I'm right at that 45 minute time zone, or time period. So hopefully that works for you, Miranda. And I just want to thank everybody for listening. I look forward to what questions and discussion might come up. Yeah, thanks so much.
Thank you so much, Dr. Heavey. That was just absolutely fascinating. I mean, I've heard you talk about different things, you know, in regards to your research. I'm an MPH student, if anybody doesn't know that. So like when we were setting up this series, I was like, I really want to reach out to Dr. Heavey because she has so much knowledge and so much experience working right in the field and everything. So thank you so much for sharing that with all of us today. We really appreciate it. And, you know, the work that, you know, everything that's being done at the university and at the county health department is so important in regards to the opioid epidemic. So thank you so much for sharing that. Please, everyone, start typing in your questions in the chat. And if you'd like to, you know, unmute yourselves, if there's anything that anybody wants to bring up, please do so. This is the time. So thank you. We'll open it up to the floor.
No questions?
I know everybody's being quiet. Oh, here we go. I knew Will was going to have one. Thanks, Will. All right. Do you think that the telemedicine shift in terms of prescribing, access to care, or quality of care has also impacted these higher number of overdoses?
That's a really interesting question. I don't think we have an answer to that empirically, but I actually think telemedicine might help solve some of these problems, to be honest. I think there's been, prior to COVID, there was a lot of reticence around telemedicine. And I think people in organizations were more comfortable using telemedicine for conditions with less stigma associated with them. So, managing type 2 diabetes, I feel like has been the telemedicine winner. We can manage type 2 diabetes with telemedicine. And I actually think once we kind of separate the stigma associated with some of these conditions like opioid overdose and opioid use, we can actually do a really good job of that. And I'm working with some colleagues at the VA to think about how we can use telemedicine around medication-assisted treatment, and how we can kind of be more open to using that as a pathway. And I think previously people were just really afraid, of using it. And now we're all using it, right? I mean, I had a family Zoom call with my father-in-law, and he's 78 and he did a great job. And so people are kind of moving away from their reticence over these virtual platforms. And I think it's actually going to support this much more than it might harm. But we don't know.
Uh-oh, we're frozen here. Hello? Did we lose?
I can see the next question if you want me to say it.
Okay, yeah. Is Dr. Heavey frozen on your end too?
Oh, yes. I'll just give it a sec.
Yeah. Sorry, everyone. It's the beauty of Zoom. All right, did we lose her? Maybe we have to.
She might log back in.
Yeah. Sorry, everyone. It'll just be a minute.
Hi, I'm so sorry. I don't know what happened, but I'm back.
Hey, that's all right. It is the beauty of technology and distance learning and all that. So no worries.
How much of my telemedicine answer did you guys get?
We got the full thing of that, I believe.
Cool. Sorry about that.
No worries. We have another question here. Is there data on COVID-related uptake of opioid use all over the country, or is it region specific? And how does it compare to Western New York?
So we don't have data on that yet. National data generally lags about a year and a half behind. So we don't have that yet. And once we do, we'll have a better sense of that. I would guess though that it's up everywhere. That would be my gut reaction. But empirically, we won't know that for some time. And to be honest, everyone's kind of scrambling around collecting COVID-related data. So I think there may be a longer delay to get some of this other traditional monitoring data because so many people are pivoting to understand what's going on with the COVID epidemic.
I'm going to unmute myself to ask a quick question, Dr. Heavey. So I work at Evergreen Health, one of the organizations that distributes naloxone. So I work in our location on Elmwood in Buffalo, and I actually saw Tiffany on here from our location in Jamestown. So we've remained open, maintaining almost a regular schedule besides cutting 1 hour a day, at least at our physical sites, continuing to distribute naloxone. So my hunch has given me like the question, is there a potential of a supply chain issue within the drug trade that's causing those selling drugs to incorporate more fentanyl than they normally would to achieve the same high of what they normally would be selling?
Yeah, I think it's certainly possible. Again, I don't think we have great empirical data on it, but I think you're certainly onto something, and that could certainly be something that's happening. There's also supply chain issues when it comes to naloxone, though, in some cases where shipments aren't coming in the same time zone or at the same time frame that they might normally have. So I think there's little challenges kind of all along the way that create even bigger ramifications. That, to be honest, I think we're just seeing the tip of the iceberg. I don't think we're done with some of these effects. Other questions?
Ooh, we have another question from Will. He says, as the director of MPH programs at UB, are there currently any classes or any type of talk focused around health equity, quality in a pandemic? He's asking as a current public health BS student.
Yes. So there's actually a micro credential in health inequities that our department offers, and it's 2 classes. It's program planning and evaluation, and then you can pick either health disparities or sexual risk behaviors. And there's a couple of other things around that, and it looks specifically at health inequities and addressing them. So you could focus in on COVID health-related disparities. There's also so many health disparities to pick from. There's lots of options. There's also in the fall going to be, there's a special topics class on the COVID, on pandemics in general and COVID more specifically, that will be addressing some of those questions as well. Since you're a current public health undergrad, I believe the code for that is Pub 400, but we can check on that for you and I can let you know. So those are 2. I can tell you that in Pub 420 in spring of 2021, which I teach, we will also be covering it in that class. So there's lots of options, and I would stay tuned. There's probably going to be a lot more around that exact issue that you're talking about. I believe there's some seminars in the works and things, so I would stay tuned. I just don't know what's released and what's not released quite yet.
Thank you.
Yeah.
We have a comment here from Alexa. She says thank you, and she's currently interning with Cheryl at the Department of Health, and said, unfortunately, we're seeing a lot of overdoses the next day due to isolation, and there's no time for Narcan, and hopefully there will be a downturn soon. So yeah, kind of touching on that topic that you mentioned of, the depression and isolation of COVID in, also comorbid with the opioid epidemic.
Yeah, it's a really challenging problem, and for some people, 12-step groups like Narcotics Anonymous are really useful. And for example, those haven't really been able to happen in the same way that they normally have. And so that might represent a gap. Now, 12 steps not for everybody. It doesn't work for everyone, but for some people, it's kind of a lifeline. And if you can't meet and connect with the people that are supporting you, that just further drives the isolation and depression related to this. And frankly, it's a hard time for everyone. It's difficult and doing things differently than you normally would. So yeah, it's Alexa's right, and it's a hard problem to solve.
Mm-hmm. Definitely. I actually have a question in regards to some of your research. You were talking about the motivation behind Narcan usage and distribution from users. So I was wondering what either the county health department or what's being done in research to kind of tackle the motivations that are underlying whether or not people will, engage in Narcan usage before using opioids or something with fentanyl, kind of what's being done with that.
So there's a lot of research going on around that, trying to really nail down what's happening. But in terms of kind of public health programs, that was one of the big reasons why Narcan that kind of text to Narcan or drop off Narcan programs that are happening. County Health Department does it. Horizon, I believe Evergreen has some kind of no questions asked Narcan, but Michael, you're welcome to fact check me on that if you'd like. But really removing any requirements around obtaining that Narcan. Like, you don't have to go and sit for 90 minutes. You can also get Narcan from your pharmacy now, and it's a quick, just a few minute education moment, not a very long and lengthy community type session. So I think kind of being creative in how we're reaching those populations. And I also think, it's so important to kind of stay away from judgment. How people use is their business. And the reason it's important to understand that is because then we can better market to people and reach them where they are, right? So even if it's have this with you so it's safer if you're experimenting, like, that's okay, right? Like, that you're meeting them where they are and you're getting a drug in their hands that could potentially save their lives, and stepping away from a lot of kind of stigma and judgment that I think the substance use field is still grappling with how to move away from that. And even actually, this is, I think, such an interesting area around medication-assisted treatment. So we have medications that we know work for opioid dependence, and buprenorphine is one of them. But a lot of places still make buprenorphine treatment contingent on, 5 or 6 other things that people have to do. And I personally really disagree with that approach. I think we need to be saying, take the buprenorphine. If you want to do a group, great. If you want private counseling, fantastic. Have those. But don't make buprenorphine contingent on those things. It's really just, again, entrenched in this stigma, and it just isn't productive. It doesn't get people what they need. It doesn't help treat the medical condition that they're dealing with. Addiction's not a moral failing. It's a medical diagnosis. And that's how we really have to meet people.
Thank you so much.
Yeah.
Anybody else, please put your questions, feel free to unmute yourself or put them in the chat.
I can also pop my email in the chat. If people have questions, they want to reach out to me individually, you're welcome to do so. So that's my email there. We've exhausted all the questions. No questions left.
No, everyone's quiet today. I guess I have another question for you. In regards to, it's been coming out in the news more recently about cocaine related deaths. I was wondering if you could talk about that in regards to opioids, and also in regards to COVID, what's being, seen in regards to that.
Yeah, so sometimes I think people might choose different drugs more based on availability than preference. So you might not be able to get your substance of choice, so you default to the available substance. So that could potentially be it. From a pharmacological perspective, the kind of upper nature of cocaine and the kind of downer nature of an opioid can really compete and create some effects that just pharmacokinetics and toxicology and things that I don't fully understand, but can create kind of a negative synergistic effect, which can make it even more dangerous. And I think that can be part of it as well. And I think, thinking about what can be hard with drug problems is people think about them very siloed, right? So somebody's, a cocaine user, or somebody's an opioid user, or somebody's a, whatever, other substances, but that's not always how people use, the opportunity to try different things and to switch, particularly among younger users, so that kind of 15 to 25, it's really more about what's available than it is preference. And so I think that can feed into this as well. But again, we know it's starting to be an issue, but we don't have great data on what exactly is happening. So it's, at this point, a lot of speculation.
Understandable. All right, last question. Unless if anybody else has things they want to add, please do so. That's what we're here for. But I know a lot of people on this call and a lot of people who have been attending this series are people from the community or, practitioners working with substance abuse or, in different medical and healthcare fields. So an upcoming kind of question we've been having is, what can we do as community members to really support individuals with addiction? And how can we help support them and decrease the stigma of opioid addiction? What can we do to support these individuals ultimately?
I think it's such a great question. And I think honestly, just being willing to ask that question already sets you apart and people thinking that apart, because you want to be helpful. And I think the biggest thing is kind of non-judgment, coming from a place of not judging somebody for substance use. Just like, it wouldn't be appropriate to judge somebody for cancer or judge somebody for diabetes. Those are not appropriate reactions, but for whatever reason, those still hang around with substance use more than I think a lot of those other conditions. And so, I think in part the kind of, like anyone who's ever talked with somebody, they know personally, not necessarily professionally, but personally, with a substance use problem or a lot of mental health problems like this too, all of a sudden they start talking in hushed tones and you start talking kind of softly, and they're kind of corner conversations. And I think that kind of just builds to it. And so just kind of being like open and yeah, okay, like this is information, like how do you feel about this? What do you think? Is this something you're looking to change? Is this something that you're thinking about isn't bringing good things to your life? Or, are you comfortable having conversations about it? Like, would you be willing to think about, connecting to someone who might be able to help you with some of these concerns? Just being open and available and, having, if you know somebody, and most of us do, I think that's the other misconception about the opioid epidemic. People think it's, not in my backyard, but it is. We all know somebody or multiple somebodies who might be struggling with addiction. And so having naloxone in those cases, if it's an opioid addiction, or kind of being familiar with potential resources for if that person ever wants to talk to you about it, I think that is helpful. And, if you're in a position where you can call people out when you see them engaging in stigma behaviors, do it. There's nice ways to do it, but you could even just say something like, look, I know you probably didn't mean it this way, but it sounds like what you said is really has some stigma behind it. Would you be willing to say it in this different way? And just advocating for people who might not feel comfortable saying like, oh, that was a really stigmatizing thing to say, or I felt really judged by that. Being willing to stand up for people in those situations, I think is important.
Well, thank you so much for all of your, answers to our questions and all of your information that you shared today. This was, so important, so informative. So really, thank you so much for being here today. We really appreciate it. And thank you everybody who has attended today. And if you attended other sessions, thank you so much for your support. We really appreciate it. So with that, sadly, usually I say next week we're going to have so-and-so, but next week, come on and say hi to me. I'm just kidding, but thank you all so much for your support. We really appreciate it. And I really hope you enjoy the rest of your day. And thank you again, Dr. Heavey, for all of for your talk and everything. We really appreciate it.
Thank you for having me. It was great to be here. And again, if people have follow-up questions, thoughts, whatever, feel free to reach out by email. And thank you for doing this great series. This was fantastic. And I'm really grateful I was able to be a part of it.
Yeah, thank you so much. Have a great day, everyone.
Bye. Enjoy. The weather is beautiful.
Thank you.